Hi, welcome to Mass Casualty Triage Training, Uses of START Triage. Let's get started. Our objectives upon completion of this training are to define triage, list 3 reasons the patient triage is required for successful operation, explain the START Triage system, and characterize the status of some patients utilizing that system. So what is triage? Triage, in the setting of a mass casualty incident, is defined as the sorting and allocating of medical treatment to patients from a battle or disaster victims through a system with the ability to increase the number of survivors. So why should we care about how people are triaged outside of the emergency department? Because we need to know who to take care of first when something major with many victims like this happens. This is the Boston Marathon bombing in 2015, taken by Aaron Tang, showing multiple victims and bystanders alike. Over 280 people were injured that day. How would we characterize which patients need to be seen first and which ones need the most immediate treatment? Or even something like this. A bus crash that happened in Bronx, New York is a mass casualty incident. This incident had 8 injured critical patients. Who do you take care of first? If you were at the scene, who would you transport first? How would you identify that a given patient has priority? Across the country, we use the START triage system. START stands for Simple Triage and Rapid Treatment. When I say rapid, it is a quick, simple, rapid to 30-second assessment of a patient with minimal intervention and tagging. You want to check for their respirations, their pulses, their mental status. Attach a ribbon to their upper arm, tag them as high priority or low priority, and move on to the next patient. There's 2 ways of doing this. Once a scene like this is cleared and safe, with people not involved in the accident, everyone left on scene is then classified using the START and JumpStart triage systems and should be given a tag or colored bands to signify their category. START is for adults and JumpStart is for pediatrics. The original triage algorithm was made by Newport Beach Fire and Marine Department in 1983. The U.S. Department of Health and Human Services made the adult algorithm on the left and the pediatric algorithm on the right. It used 3 main colors: green for minor, yellow for delayed, red for intermediate, and black for deceased. Remember, this is a basic, quick triage assessment, not full stabilization and treatment. That's done in the emergency department. We will go through each step of these algorithms with a focus on the adult with pediatrics in between. Let's start with the most stable patients. If they can hear, ambulate, and follow instructions, they are considered green, also known as the walking wounded. They should be given verbal instructions on scene to move to a safe area. They would be given a green tag and will be reassessed, but injuries are unlikely to deteriorate over the next day. If your patient looks like this guy, eating a sandwich or calling for food, I think he is okay and will be given a green tag and instructed to go to a safe area. There are 3 decision criteria to be used in characterizing those patients who are left after the walking wounded green tag patients have gone to their safe designated area. Basic mnemonic I want you to remember is RPMs, like the gauge in your car. RPM stands for respiration, perfusion, and mental status. This sounds very similar to your primary survey in trauma. ABC, airway, breathing, circulation. Is my patient breathing? Are they moving blood through their body? Is the blood making it to the brain? R stands for respiration. Is the patient breathing? If the answer is no, position the airway using a jaw thrust. If respirations begin, the patient is tagged red, immediate. If the respirations remain absent, they are deceased and tagged black. In pediatric patients with a pulse and no breathing, you can intervene using 5 rescue breaths. If they begin breathing, they are tagged immediate in red. If respirations remain absent, they are tagged black or deceased. If the patient is breathing, the START adult pathway magic number is 30. Respirations under 30 means move on to P for perfusion. Respirations over 30 means that the patient is tagged red immediate and you move on to the next patient. For pediatrics, the magic numbers are 15 and 45. Respirations between 15 and 45 means you move on to perfusion, or P. Respirations outside of this range, either too high or too low, characterize the patient as immediate in red and move on to the next patient. P is for perfusion. During perfusion, a radial pulse and a capillary refill are checked. If the patient has a radial pulse and a capillary refill less than 2 seconds, they are clear and move on to M for mental status. If no, they are tagged red. This assessment corresponds to C of the ABC's trauma scale. After assessing respirations, if the patient passes, they move on to P for perfusion. Remember, all patients are breathing and therefore have some perfusion. Radial pulselessness does not mean cardiac arrest. It means very poor perfusion. Anyone with a radial pulse who has delayed cap refill is automatically characterized as red regardless of their age. M is for mental status, or perfusion to the brain. In adults, we are evaluating if the patient obeys a simple command like, open your eyes, or what is your name? In children, we are looking for AVPU to determine red or yellow tags. Children who are alert or verbal are yellow tags, delayed. Children who are posturing or unresponsive are red. Remember, RPM is performed in order. Patients will be characterized as a red or intermediate tag whenever they fail an RPM step. Just a comment about the yellow delayed transport patients. These are patients who by default are not green or red. Although they are not immediate transfers, unlike the red patients, these patients are at risk for decompensation and require careful, frequent reassessment in the field and in the ED. If the patient is immediate, before moving the patient, you can attempt a life-saving intervention. Only emergent and life-saving interventions should be performed at this stage. Airway manipulation, needle decompression, tourniquets, or toxic antidotes. All other interventions should be made at the treatment area or emergency department. Here is the full adult start algorithm. Pause the video if you need. Here is the full jumpstart pediatric algorithm. Pause the video if you need. These algorithms are also available as posters and pocket cards. Of significant importance are children and the elderly. Parents who are green tag will often carry their children to the green tag area, and then their children are not assessed. These kids need to be found and assessed because they may need immediate transport. Look at this guy on the right. Because of his scooter, he can move fast and may be found in the green area, but still needs to be reassessed to make sure he's not an immediate patient. Alright, let's start triaging some patients. For each case, I will give you a few seconds to answer. I encourage you to pause this video, think, and then answer on your own. For each scenario, ask yourself the following questions. What color is the patient? If the patient is red, what interventions can you provide? And which patient should be transported first to the hospital? You are the doctor on your EMS ride-along. Your unit is called to the scene of a bus versus car accident. Radio states multiple injured patients. EMS team gives you a triage tags and asks you to rapidly assess the victims. Patient 1. First thing you see looks to be in his 50s, walking around the scene, asking for help. As you approach, he states, "My wife is in the car. Please help her." You ask if he's okay, which he responds in the affirmative. How would you tag this patient? If you said green, then you got it. This patient is walking, talking, answering questions appropriately. Best thing is to give the patient green band and move the patient clear from the scene. Patient 2. You walk up to the car and see a woman, maybe mid-40s. Head against the steering wheel, blood noted from the ear. You shake her with no response. You hear minimal breath sounds, respiratory rates in the 20s, carotid pulse greater than 100. How would you classify this patient? As per RPM, respiratory rate less than 30, pulses radial not present, does not follow commands. This patient is red or immediate. Patient 3. You enter the bus and note the driver is screaming in pain. Deformity to the left arm with glass shards protruding from the skin. Patient repeatedly states it hurts. Radial pulses are intact. Respiratory rate 28, heart rate 118. You ask him if he can move. He states he can't move his arm, but is able to move other extremities. How would you classify this patient? If you said yellow or delayed treatment, I agree. Pulses are intact, he is speaking, and able to follow commands. Patient 4. You note a roughly 30s male is on the bus floor. He wakes up when you shake him. He's notably tachypnic with a respiratory rate of 32. He's bleeding down his leg with his foot stuck between the bus seat. Radial femoral pulses are palpable. How would you classify this patient? If you said red, I would agree. Can you do anything for this patient? Here, due to the bleeding, you can apply a tourniquet to his leg. After the intervention, he's talking to you, screaming in pain. He's vitally stable, demanding transport. Femoral pulses remain intact. Can you reclassify this patient? Yes. He is now a yellow tag. His vitals have stabilized, however, he needs an acute intervention to get there. So he is automatically yellow, even though he is now walking and talking. Good job. This ends our mass casualty incident and start triage training. Thank you.